Hello, everyone, and welcome to our afternoon session. Today we're going to be presenting Rehabilitation Connect Forum, Part 2, Adults. I feel like I should have a deep voice for that and introduce it more as like Part 2, Adults. But okay, not funny. Anyway, moving on. So I'm Lindsay Zombeck, and I'll tell you a little bit more about myself in a little bit. I want to take this opportunity to welcome everyone. I'm very excited to have this opportunity, and I'm very grateful to Amy Byreth and to American Cochlear Implant Alliance for creating this fantastic opportunity to talk about rehabilitation in general and to select sessions from all the different abstracts that came in that are related to, in this case, adult oral rehabilitation. So I'm really excited that there's a lot of people here that we can talk about adult oral rehabilitation, because I think a lot of us are in agreement that it's not necessarily getting the focus that it deserves. So thank you all for being here, and let's get started. I'm going to tell you briefly about each of our speakers, and then we'll turn it over and get going with these presentations. We have a joint presentation from Blair Richland and Megan Reed. Blair Richland is a speech-language pathologist and listening and spoken language specialist at Mass Eye and Ear. She is currently enrolled as a PhD student at Idaho State University in the Rehabilitation and Communication Sciences program. As an expert in modalities, she is highly specialized to provide support for listening and spoken language, total communication, augmentative and alternative communication, and maximizing auditory input when American Sign Language is the primary language. She will be joined by Megan Reed, who is the Director of Clinical Audiology at Mass Eye and Ear. She is an audiologist with over 20 years of experience. Her interest focuses on improving access and affordability of hearing healthcare. We'll also have a presentation from Dr. James Dornhofer. Dr. Dornhofer is the Senior Neurotology Fellow at the Mayo Clinic in Rochester, Minnesota. He has research experience in the areas of outcomes and quality of life within otology, with a particular interest in the rehabilitation of sensory neural hearing loss via cochlear implantation, and specifically in interventions and therapies that can improve implant outcomes. We will also be hearing from Michelle Havlick, who is a speech-language pathologist who specializes in listening and spoken language development in children and adult patients with hearing loss. She's worked at UChicago Medicine and is a member of the Pediatric Cochlear Implant and Hearing Loss Program. She is a listening and spoken language specialist, certified auditory verbal therapist, and a credentialed early intervention specialist and evaluator. In addition to her work at UChicago Medicine, she's presented at professional conferences, served as a consultant in research studies, and she was an adjunct professor for St. Xavier University's Communication Sciences and Disorders Department. We'll also be hearing from Dr. Taryn Tamati, who has a PhD in linguistics from Indiana University. She is currently a research assistant professor in the Department of Otolaryngology at Vanderbilt University Medical Center. Her research focuses on the linguistic, cognitive, and perceptual skills necessary for listeners to understand speech in real-world challenging environments. Through her research, she is interested in identifying factors underlying individual variability in adult cochlear implant outcomes. You will also be hearing me. I am Lindsay Zombeck. I am a speech-language pathologist and a supervisor for speech-language pathology at University Hospitals Cleveland Medical Center. I work with the Cochlear Implant Program and provide oral rehabilitation for children and adults who are deaf or hard of hearing. I have published chapters and articles related to my work, and my research interests include investigating cognitive predictors of outcomes in adult cochlear implant recipients and the role of speech-language pathologists in adult oral rehabilitation and outcomes. So these are our presenters, and I'll be turning it over.
Okay, look at Anita and say cheese.
How do we do this? Progress.
Okay. Hi, I'm Blair Richland. I'm a speech-language pathologist and listening and spoken language specialist, and I work at Mass Eye and Ear Infirmary, and this is my boss, Megan.
Hi, I'm Megan Reed. I'm the Director of Clinical Audiology at Mass Eye and Ear.
These are our disclosures. ASHA defines oral rehab, or AR, as audiologic rehab, auditory rehab, hearing rehab, and rehabilitative technology. Some terms are more commonly used to refer to services provided by an audiologist, and you see that in the picture behind me. And some terms are more specific to services provided by an SLP. If you're here to learn how to do AR, this isn't it. I'll do it. I'll teach you and talk to you about how to do AR maybe next year, maybe a whole day next year. Who, board members for ACIA, are you listening? While oral rehab as an umbrella term encompasses services by both an SLP and an audiologist, we're discussing the care that an SLP would provide to a cochlear implant recipient. Why AR? Why build a program? We know AR as a practice works. It's in the literature. It's supported. Despite this, there are limited centers that provide the service. Why? Well, there are provider shortages. We know that. There is a lack of education and graduate school training for SLPs to learn how to do AR. There's a misperception that patients don't want or need this service. Not true. And there's a misperception that this service is not reimbursable. But we'll tell you otherwise today.
So Mass Eye and Ear has had an oral rehab program for over 15 years. It was primarily focused on communication strategies. We recognized that there was an unmet need for the other oral rehab services that fall under the umbrella. And so we were lucky enough to convince Blair to come up to Boston and join us there and help us revamp and rebuild this program.
The first step in rebuilding a program, because Mass Eye and Ear has been a very successful cochlear implant program for a very long time, and they have a massive team of audiologists. There are 57 in total when fully staffed, I learned just now. I had to better understand what the perspectives were from the audiologists and the surgeons regarding AR, their comfort levels for referrals, and the areas that they felt a service provided by an SLP was most needed. So I surveyed them, and the most responses indicated a need for adult therapy services. Go figure. Megan and I took that opportunity to do the protocol change with the intention to offer this service to all of our cochlear implant recipients. We are now over a year out. How do you think we did? The overhauled protocol entailed a pre-evaluation with me that occurs during the cochlear implant candidacy process. This allows the recipient to discuss communication strategies while they're waiting for their surgery, develop an understanding of expectations for listening practice and all of the work they're going to need to do, and education related to their new device and how to support their functional listening skills. The goal of by 3, a second evaluation following the recipient's 1-month post-activation appointment with their audiologist, that occurs by 3.
So we made the decision to switch to a by 3, really to allow flexibility for recipients to have at least that critical time period where with their new device so they can have the kind of the natural progression of their performance before starting to implement and enforce a more rigorous and concentrated training process.
And therapy is offered if needed for the recipient, and that involves education, support, coaching, troubleshooting, and auditory training. We've been offering virtual and in-person appointments, but I highly encourage that the appointments with adults occur virtually because I want to isolate the cochlear implant and I don't want interference from residual hearing or their other ear. Let's see how we did. The audiology department experienced a 104% increase in attended adult evaluation appointments, virtual and in person, as compared to the previous calendar year.
You'll notice about 50% of the patients we saw for evaluations were seen in person compared to about 50% for virtual compared to our post-therapy sessions. Given the age range of this patient population, their comfortableness with technology, and perhaps their lack of understanding of what an AR evaluation is, many patients are more comfortable coming in person for that evaluation. But once they meet Blair and get a better understanding of what AR therapy does and the importance of isolating that implanted ear, there's more buy-in for a virtual appointment.
Yeah, I make them. Adult therapy drastically increased, and 55% of patients who completed the initial AR evaluation participated in therapy, virtually for the most part. And we feel that development of a defined referral protocol directly contributed to this increase in services.
So while evaluations increased over 100%, we still have an untapped volume of patients. You'll see that 28% of our patients came in for oral rehab evaluations. While we're happy that the majority of our patients were seen for therapy, we still want to look at that untapped volume of patients who, 72% of our patients who, cochlear implant patients who did not have an evaluation, and see if we can build on that going forward.
In terms of timing, the majority of initial evaluations occurred by 3, so that time point in the protocol, rather than pre. Obviously, we're looking into how we can address this in the referral process as part of their pre-evaluation, and given the volume increase achieved in only 1 year, scheduling availability does play a part.
So we also looked at the referral because it was really important to get the buy-in from the audiologist and the otologist. So we looked at referrals for AR for our adult patients for the audiologist. We were excited and happy to see that 2/3 of our cochlear implant audiologists referred and recommended AR services by looking at audiologist patient notes. However, the majority of our audiologists referred less than 2 patients in a year in the first year. Given our program sees about 200 cochlear implant surgeries per year, this is an area of focus going forward. How can we build and improve upon this?
The patients represented on this graph received a cochlear implant in 2023 and returned for at least 1 therapy session following their evaluation. Participation in therapy averaged over 3 sessions, and they were typically offered on a biweekly or monthly basis. Because of our established protocol with ongoing therapy, I'm able to follow the patient in conjunction with their audiology follow-up appointments and provide feedback that, yes, will influence programming. In 2023, patients seen for therapy were predominantly Medicare. This may not be surprising to you, adults. Now Megan's going to talk about the money.
All right, so you might be not surprised that one of the questions we get a lot is, can an AR program be financially solvent? To answer this question, we did look at our first year finances. We talked about what options and what kind of billing structure we wanted to fall under. We did decide to bill under 92523 for speech sound evaluation, and then 92507 for therapy following the Medicare guidelines and requirements. Given the volume of our patients for our adult program who all have Medicare, these were the codes that made the most sense. We have also found that most of the insurances offered benefits for therapy in the same capacity using these codes. Want to point out and be clear that audiologists cannot use these codes because they are SLP specific. We looked at and considered the use of 92626, but given that sometimes these services happen simultaneously with cochlear implant services, we decided to steer away from that. We did look at and find that 78% of claims did pay out as expected, which is pretty solid for our first year, but we are looking at that 22% of claims that didn't pay out the way we wanted to, mostly focused around prior authorizations and some billing concerns. We then looked at reimbursement and revenue for evaluations. We are happy to say that overall reimbursement across payers averaged about 50%. I do want to point out that this reimbursement, our program does include both adults and pediatrics, so this revenue does encompass both of those, but so we would expect that an adult-only program is going to have a higher volume of Medicare patients. I do want to just point out one payer in particular. This payer is linked with our healthcare system, and the way the contract is set up with this payer is that regardless of service or cost or charge, we are paid a set fee. So for oral rehab, this is beneficial. We are getting paid more for service than we are charging in those situations. However, overall, as a cochlear implant program for that payer, we are getting very little money and lose out on that service. So the goal of this contract with this payer is to be net neutral across the system, which is why they've taken this approach. And then we also looked at reimbursement and revenue of therapy. Similarly, AR therapy paid out about 50%. There are two examples that I want to point out that didn't reimburse as expected. Aetna, as a private insurance, was not reimbursing the 92507 CPT code for therapy. So we did not get paid for most of the therapy sessions we saw that cycle. We are working and exploring whether changing our coding for a payer specific using the 92630, 92633 codes would improve payment in that situation. We also expect that Medicare reimbursement will increase. We ran into a billing provider issue that we are working on addressing and anticipate this will increase in the coming year. I think the key takeaway for this is that payers do overwhelmingly reimburse for these services, but there also might be issues with payers that you need to work out depending on your individual contracts. But to answer the question of can an AR program be solvent? Yes, with our year one billing for audiology rehab programs and services, the service was profitable. We were able to do this by minimizing additional costs outside of salary and leveraging, as a large program, a large audiology department, leveraging resources we already had in place. Given that our volume or evaluations this year was only 28%, we do know that there's opportunities to grow and expand, and we are going to need to hire additional speech pathologists to help do this. And so I think this data is a great argument to our hospital to help invest and support this program.
We're holding interviews during happy hour, 10 more SLPs. In conclusion, initiating a structured adult AR program as a component of whole patient care for cochlear implants resulted in value. Yes, value financially, but we also know that patients like it, and it's better care in general. But since we are out of time perfectly, we'll have to share that outcome data next time. Thank you so much, and we'll see you next year in Boston.
Good afternoon, everybody. Thanks for taking your time to come to this session, and thanks for inviting me to talk today. Now, I'm going to switch gears a little bit, and I'm going to talk about some results from an ongoing observational study looking at a lot of patient-directed interventions in new adult implant recipients. Namely, a lot of things we recommend patients try, exercises, computer programs, and we want to see if they help influence outcomes in that first year after activation for new adult implant recipients. So here are our conflicts of interest and our sources of funding. Now, as I'm sure we're all aware, cochlear implants have seen exceptional success in the management of advanced sensorineural hearing loss. But we still do see a good deal of variability, which cannot be entirely explained with implant design or cochlear health. And we hypothesize at least some of this variability is related to a patient's ability to learn to hear with their device. This takes anywhere from several months to a couple years. And there are some processes to help improve or hasten this. For example, auditory training, either face-to-face clinician-directed exercises they can do at home, like listening to an audiobook or listening to radio, or a number of computer-based programs such as Sound Success or Angel Sound. Now, we previously presented on some data in a similar group of patients that the use of certain programs, namely computer-based programs, seem to afford some unique benefits, namely greater improvement in speech recognition and a number of quality of life metrics at 3 months after activation. We also saw some quality of life benefits with the use of clinician-directed exercises as well. However, this is at 3 months after activation. This is still where a lot of patients are seeing a pretty precipitous improvement in their functional speech recognition skills. Though this may not represent, the real true or final benefit for many patients. So moving forward, in this study, we're going to continue following that group of patients in addition to adding several more to see whether the use of various exercises, programs, or various training algorithms may have any benefit with respect to speech or quality of life in new adult patients at 1 year after activation. To do this, we utilized a prospective cohort of new adult cochlear implant recipients receiving an implant for bilateral hearing loss, namely a group of patients which is reliant on that implant. We followed these patients over that first year after activation. At regular time points during that, we surveyed them on their auditory training habits. Usage of any training was solely voluntary, and for the purposes of this study, we grouped discrete different exercises or programs in one of the following groups. We had face-to-face speech therapy sessions, such as work with a speech-language pathologist or dedicated time with an audiologist outside of programming, which focused on speech training exercises. Passive home-based exercises, these are things like listening to an audiobook, radio, or TV with captioning. And computer-based auditory training programs, which included things like Angel Sound, Sound Success, LACE, those sort of things. Outcomes for the study were change in speech recognition and change in quality of life as measured with the cochlear implant Quality of Life 35 profile from pre-implantation to a year after activation. Ultimately, we enrolled 114 patients in our study. Demographics generally mirrored those seen at our institution, and when we looked at different usage groups, as we will in a minute, the demographics between those groups showed no significant difference either. Considering what people actually trained, we saw that most people at a year did do something, with a majority utilizing a passive home-based exercise, a little less than half using one of those computer programs, and then about a fifth using a clinician-directed resource. Of note, patients could use more than one type of resources, which is why you'll note that does not add up to 100. Now, talking about outcomes now, as a whole, this group did well with their implant. And on average, we do see a good improvement. Now we'll talk about how some of those resources may have influenced that improvement. And I do want to highlight real briefly, we're going to be talking about improvement in these various outcomes, meaning that all these patients did show some improvement from pre-op, just some may show more or less. So I don't want you to think that someone didn't get any improvement with their implant, namely whether or not they had additional benefit with this training. So looking at face-to-face and passive home-based exercise in this training group, we did see, at least at a year, used in this fashion, they did not show any greater benefit in speech or quality of life. Nor did we see that actually in this group that hours of CI use was significantly associated with speech or quality of life benefits, but we'll talk about that later. However, with computer-based auditory training, we did see some benefits. Now, as you may recall from that first slide, or a slide earlier, at 3 months, patients who used these training programs saw improvements in both speech and quality of life. At 12 months, we see that there actually was no longer a significantly greater improvement in speech, as other groups who did not train with these resources did appear to catch up, perhaps due to other training effects or just due to passive acquisition through use of their device. However, we still do see that patients who use computer-based auditory training have a significant benefit with quality of life. Here we've graphed change in quality of life, and in blue we see patients who use these computer-based auditory training programs. And we see that they have significantly greater improvement in global and all domain scores for the quality of life profile, with large effects for social and global scores and medium effects for the remainder. We then performed the multiple regression to control for demographic co-founders and the concurrent use of multiple resources at the same time. And again, we see that the use of computer-based training programs was significantly associated with greater improvement in global and all quality of life domains. So from this, we see that computer-based auditory training programs may offer some benefits, persistent at least out to 12 months in new adult implant recipients that seem to be unique compared to other commonly available forms of auditory training, or at least those that are offered to many patients. There is, as mentioned in our previous talk, literature to show support of various training algorithms exercised in the literature, but much of it is relatively limited in its small sample size, reliance on already experienced implant users, and oftentimes a very strict laboratory settings. So I feel this does offer some encouraging, relatively novel data of the use of these resources in a clinical setting. However, we do have to talk about that evolution of benefit over time. Again, at 3 months, use of these programs was associated with both speech and quality of life benefits detailed in the graph on the right, patients in blue being those who use computer-based training. We see that at 3 months, we see a benefit at both speech and quality of life, but at 12 months, that speech benefit goes away as other patients sort of catch up, but we still see that persistent quality of life benefit. I'm actually going to show you some other results from a more recently accepted study in which we actually looked at patients who started using computer-based training at different times. And we see here, this illustrates it similarly, at 3 months, patients who have used resources at this time do show a benefit, whereas those who have not started training yet or never will have less improvement in speech recognition. But as detailed in that graph, by about 12 months, we start to see all those groups converge as people seem to reach the kind of steady state speech recognition. But again, like I mentioned, as you saw earlier, the story is not necessarily the same with quality of life. Here again, we have those same groups. In green, those who started training by 3 months. Yellow, those who have not yet started training by 3 months, but will by 12. And in dark blue, we see those who never trained. And we see again, 3 months, the expected benefits in those who have already trained. But then by 12 months, we actually see that those who never train kind of stay on that lower trajectory, and that people who start training early or late do seem to have a persistent benefit. And we also think this graph is kind of notable in that we do see a kind of trajectory change in those who have not yet trained at 3 months, and then those who, but then eventually do by 12. They start kind of in that lower trajectory with those who never train, but then show kind of a shift up to a more favorable trajectory with those who are able to start training earlier. So I think very encouraging that this is a true effect we're seeing, and also encouraging to see that we see a benefit even if started later in that post-implant period. So this kind of summarizes it in more detail, but from all these results I've shared with you, we feel that we've demonstrated that use of computer-based auditory training at any time in that 12-month period after activation may afford certain benefits with quality of life. We can't really say for sure why it is we see these persistent benefits despite the fact that speech benefit goes away, but we may hypothesize it may be that earlier acquisition of speech skills may afford good habits or confidence that is nonetheless reflected in quality of life improvement. Or it could simply be that many common quality of life tests don't assess, real world functional benefits or skills that are nonetheless reflected in a quality of life metric. Now, there are a lot of limitations to this. We are very reliant on patient self-report and cannot control for the accuracy of that. We have a relatively small sample size in certain groups, especially the face-to-face training group, so we cannot necessarily say with great confidence the benefit one would have from that. And there's a very obvious selection bias. Patients could do what they will. Some patients may not be able to start training early on. Some patients who, especially those who look at clinician-directed resources, may be struggling. That's why they, went out of their way to get a referral, or maybe why their audiologist or clinician made that referral. So we have to be very well aware of that selection bias and how it's going to influence these results. However, we feel that, at least from the data presented today, that we see some encouraging preliminary evidence that the use of computer-based auditory training resources is a very reasonable option to help improve new adult cochlear implant outcomes, especially given that most of these resources are easily available and either free or very low cost online. And we see that these benefits are durable at least out to 12 months, so this isn't a fleeting outcome that goes away. It seems to, help build some sort of benefit that we're seeing reflected in these quality of life scores. That said, given many of the limitations described earlier, we still do need to do randomized controlled trials. We need to control for many of these confounding factors. We tried to control for things like, how comfortable someone was with technology, how often they use their implant. We didn't see any significant differences, but there could be some X factor out there, motivation, support that we just can't control for in an observational study. And further studies are also needed to really better define a good algorithm or specific regimen, how often to do this, when to start it in certain patients. So we still need further detail on that as well. That said, I think some at least encouraging results in my mind, and I'd just like to thank you all very much for your time here today. Thank you very much for the team at MUSC for their ongoing support with this project. So thank you all very much.
Okay, I just want to make sure I know how to use this clicker. My name is Michelle. I am an SLP AVT, as was mentioned, at UChicago, and I'll be speaking with you about our adult oral rehab program today and the results of a CI patient survey on perceptions of oral rehab and quality of life. I have to say I started as a pediatric AVT, but we've been doing adult oral rehab since 2012, and it's a special place in my heart, and I'm so glad it's getting attention today, so thank you for being here. I have no disclosures. So what do our evaluations look like? They're scheduled at 4 weeks typically after CI activation, but there are exceptions where I will see an adult prior, especially when audiologists or ENTs are concerned about inappropriate expectations or cognitive linguistic concerns. But these are the main components of our typical evaluation, which is an in-depth interview with the patient and whomever they bring to their appointment to really get a sense of what's important to them and where they're struggling. We administer the CI2024 questionnaire and also complete a holistic informal assessment. And by holistic, I mean that, yeah, we're looking at auditory functionally, how they're using that, but using screeners and things of that nature. But we're also informally assessing their use of strategies, accommodations, comfort with technology and accessories, and looking at their expectations and so on. And this is all tied up in a little bow, and alongside the patient, we work on customized goals to target their quality of life, not just their auditory skills, and we work together to create a home auditory training program as well, using whatever tools they're comfortable with and have access to. With regard to treatment, it is individual, based either video, in person, or a combination of both, and the frequency can vary, but typically we see patients monthly for the first 6 months. But the focus again is not on just auditory training, but how to help patients navigate life with hearing loss, this new technology, this new way of hearing, and continue to develop that home auditory training program. During therapy, I feel like I wear a couple hats. I feel like I'm part personal trainer and part cheerleader. Some patients need more of one than the other. As a personal trainer, I feel like we focus on regular assessment of their functional audition, checking on their progress with their home program that we've developed together, and education on strategies that they can implement into real life situations and report back on what's worked, what hasn't, and adjusting as needed. In the cheerleader role, that's kind of obvious. We're looking to focus on the wins, reminding them of how far they've come, and educating on what's normal to expect this soon after activation. So the title of this presentation includes a mention of our collaborative model. I feel very fortunate to be part of a supportive team that weaves the importance of oral rehab into every part of the CI process. We set the stage for this by providing annual oral rehab in-services to our ENT residents, medical students, externs, and new hires so that they know what oral rehab is and why it's important. Our team has created a way to automate oral rehab referrals into our EMR to make sure that we don't miss anyone who could benefit from this service. And we also have a CI handbook that they've developed to give to prospective CI recipients. And our ENT and audiologists are awesome about providing pre-op education that includes talking about the importance of oral rehab. And this collaboration doesn't stop there. After surgery and activation, we'll schedule co-treats, but more often we do collaborative same-day appointments where I'll see the patient, for example, first, analyze their functional audition using speech acoustics, looking at what frequency bands are really being affecting their speech perception, and sharing that with the treating audiologist, and that can help sometimes streamline their programming appointments with the patient right after. Obviously, we speak about our patients at team meetings and provide appropriate referrals as needed as well. So what's the challenge? Part of the reason that we are all here today is we recognize there's limited adult oral rehab research out there, although I'm very encouraged by everything that people are saying today. But we do know improved speech perception does not always equal commensurate improvement in quality of life and in CI satisfaction. And our team has always wondered, why is this? So anecdotally, I've always felt like oral rehab works with adults, and we've had positive feedback, but obviously that's not a scientific measure. So we've been getting a lot more CI referrals from outside centers that don't provide adult oral rehab, so that begs the question, how do we demonstrate that it is an effective way of helping a better experience for our CI recipients? How does it contribute to improved quality of life? And how do we improve our oral rehab program and make sure it's evidence-based? So as a first step in that process, I developed a survey as a proof of concept and kind of a program quality improvement project. And the survey looked at our CI patients' knowledge of AR services, their interest and barriers to AR, their perceived quality of life changes for those that did do therapy with us, and their preferences for what it looks like, duration, frequency, format, content, and then just their overall perceived CI satisfaction. And the goal was to provide a clear focus for future research and to get ideas for quality improvement. So who did we survey? It was sent to our adult CI recipients from the past 3 years with any hearing history. They did have to have their MyChart activated to receive a link to the digital survey. So we had a total of 53 participants complete the survey. Of that group, 38 reported having completed oral rehab with us, and we'll call that the AR group, and 15 did not complete AR, so we'll call that the no AR group. 83% said that they wore their CI more than 10 hours a day, 4% never wore it, 53% said they learned of oral rehab from their audiologist, yay, and 38%, I thought this was really interesting, reported that AR being offered by UCM was a factor in them choosing to use our CI center. Other interesting things that came out of this was the no AR group. There were 15 respondents. Half of them agreed or strongly agreed to the statements, my quality of life has improved since CI, and I'm happy I underwent CI. 14 out of 15 said they would have participated in therapy, however, and so there was another question that looked at what were the barriers, and the two really primary reasons were they didn't know what it was or they didn't know what was offered. Of note, I'm hoping that these barriers have already been addressed by our team since the survey captured patients implanted prior to us implementing things like the CI handbook and the automated referrals. So in the interest of time, I will breeze through this very quickly, but of the 38 patients in the AR group who were asked to rate their perception of oral rehab's impact on their quality of life from a choice of 28 possible topics, they rated on a scale of 1 to 5. Purple is strongly agree, green is agree. And as you can see, strongly agree was the majority of answers to these statements, including 73% agreed to the statement that their quality of life had improved since CI, 76% reported CI satisfaction. They also felt that oral rehab improved their feelings of safety and independence, confidence in daily communication exchanges. They also felt like topics covered helped them communicate better in noise, improved effectiveness of audiology programming visits, and helped them understand their progress and help them adjust their expectations. Lastly, they said that oral rehab improved their ability to socialize, enjoy entertainment, reduce frustration from hearing loss, and over 80% said that they were glad they participated in oral rehab and would recommend it to future CI recipients. The AR group were also asked to rank their favorite topics. So there were 14 total. All of them said that they were helpful, but these were the most popular. And as you see, none of these were related to direct auditory training. They were really focused on navigating real life situations, understanding progress, and their expectations. An interesting thing that we learned also is that the majority of the oral rehab group would have preferred that their evaluation be scheduled prior to surgery, which was not our protocol typically. And the feedback from our patients was there was like a write-in box that they could have liked oral rehab to get the strategies to navigate real life situations with hearing loss before being implanted, which totally makes sense, especially for those with a sudden or recent progression of hearing loss. And also the ARA group overwhelmingly reported participating regularly in their home auditory training program And most popular format was those computer-based or cell phone-based auditory training apps. Although to be fair, this was a digital survey and you have to be kind of tech savvy to fill that out, so it could have been a little biased. So what are the takeaways? Certainly it leaves us with more questions than answers, but of the total surveyed, a good chunk of patients chose our program in part because oral rehab was offered. So does this indicate that CI patients are now expecting AR to be offered as part of a comprehensive CI program? Perhaps. Of the no AR group, half said that their quality of life improved and they were happy they got implantation. Almost all would have participated in therapy had they had the opportunity. So this really emphasizes the need for centers to educate about oral rehab, consider offering it, and track the outcomes. And perhaps a higher percentage would have reported improved quality of life in this group. We don't know, but it is an interesting question. And then oral rehab group, in contrast, said that a large majority said that their quality of life and CI satisfaction was stronger and better, and that they participated regularly in auditory training. So they overwhelmingly perceived oral rehab as an effective and worthwhile service, and we all want happy, satisfied cochlear implant recipient patients, correct? So does oral rehab improve oral speech perception and quality of life outcomes? We're seeing a trend that, yes, that's the case, but we need more data. And could it increase our revenue with speech pathologists providing billable services and reducing time audiologists spend on counseling and education? We're seeing evidence today that that's the case, and we need to collect more of that to prove that case. So with the, so my time is running low. I'm going to wrap up here, but obviously there are some limitations to this. We can't make definitive conclusions. However, for what it's worth, patients did overwhelmingly feel like oral rehab had positive benefits on their quality of life. So what can we do? We're going to continue educating our patients, maybe adjusting personally our protocol for initial evaluations, timing, and implement a future survey on oral rehab research that is more standardized using benchmarks over time. And there's going to be more future presentations to come on that. And what can you do? You can at least educate providers and patients about oral rehab, implement oral rehab with your patients, share outcomes. We love to collaborate, and please share that. We love to learn from what you do. Here's some ideas for future research, and I look forward to keeping the conversation going later today. Thanks for having me today.
Thanks, everybody. I'm Taryn Tamati. I'm going to talk about social networks and quality of life in adult cochlear implant users. Here are my disclosures. Okay, so as we've already seen many times throughout this conference, we know that adult cochlear implant users display vast individual differences in speech recognition and hearing-related quality of life outcomes. Just to highlight this variability, here I've plotted the number of CI users who have achieved different levels of speech recognition accuracy on a sentence recognition test. As you can see, while several of these adult CI users are doing quite well, scoring above 80%, several are also performing quite poorly. A considerable amount of research has examined different individual demographic, auditory, and cognitive factors that contribute to this outcome variability. But unfortunately, many of these factors are largely outside of patient or clinician control. We propose that identifying modifiable factors can help us to define potential targets for rehabilitation. So today I'm going to talk about the social networks of adult CI users. The social network is the structure of social interactions and personal relationships linking individuals, as in this figure. Importantly, social functioning is modifiable and remains responsive to interventions throughout the lifespan. But what can social networks tell us about CI outcomes? There's some evidence that social networks directly impact communication outcomes through the auditory input that they provide. Social networks and the communication partners within those networks determine the amount and quality of auditory input that a CI user experiences. Previous research has also shown that larger and more diverse social networks are associated with more accurate speech and language processing, at least in adults with normal hearing. There's also evidence that social networks indirectly impact communication outcomes. Communication partners provide motivation and assistance in navigating social, emotional, and communicative challenges. And although not well studied, there's evidence that increased social support is linked to better communication outcomes in adult CI users. More broadly, we know that larger and more diverse social networks are associated with stronger cognitive functioning and greater well-being in adults without hearing loss. So for this current study, we really wanted to establish this relationship between social network factors and outcomes in adult CI users. So our question was, are larger and more diverse social networks associated with better speech recognition and real-world functioning in adult CI users? 26 postlingually deafened adult CI users participated in our study. All were experienced CI users with more than 1 year of CI use. Participants completed a very detailed lab-developed communication questionnaire. With this questionnaire, they listed the number of regular communication partners, as well as key attributes of those communication partners. For example, in this figure on the right, this participant may have listed 7 communication partners, as well as details on their partner's age, level of education obtained, and accent. So social network size was defined as the number of regular communication partners, and social network diversity metrics were calculated for those 3 attributes: age, education, and accent. Max proportion scores were calculated as our diversity metrics, and these were the proportion of the social network represented by the largest group. So just to give you an example, here on the right, we see 2 individuals. For both of these individuals, the blue people represent the largest group. Could be age, education, or accent. For the individual on the left, however, the blue people represent about 50% of their group, and for the individual on the right, the blue people represent 83% of their group. So we would say that the individual on the left has higher age diversity than the individual on the right. Just to note that based on how we calculated these scores, higher diversity scores represent less diverse networks. So we would expect a negative correlation between these diversity scores and our outcomes. So just to give you a sense of what the social networks of our participants look like, here I've listed the size and diversity metrics for our participants. As you can see, our participants showed wide variability in their social network size, as well as the diversity of their networks, as you would likely expect. These metrics were compared to several outcome measures. To assess speech recognition outcomes, participants completed word and sentence recognition tasks administered in quiet and in multi-talker babble. Participants also completed measures of real-world functioning. The SSQ was used to measure self-perceived hearing ability in various real-world situations. We also assessed hearing-related quality of life using the NCIQ and CIQOL 35 measures. So for our results, first for speech recognition, the moderate to strong correlations are highlighted in yellow here. So as you can see, our age diversity metric was most consistently moderately to strongly correlated with our outcomes. As an example, here I've plotted the relationship between age diversity and sentence recognition in multi-talker babble here on the right. You'll note that individuals with greater age diversity having smaller scores, Diversity scores tended to perform better on our speech recognition task. Social network size and the other diversity metrics were only weakly related to speech recognition outcomes. So these results suggest that more diverse input from different age groups may facilitate speech recognition in adult CI users. Here for our results on the real-world functioning. Again, we see that age diversity was most consistently moderately to strongly related to our questionnaires, and was significant. This metric was significantly correlated with our overall scores for SSQ, NCIQ, and CIQOL, as well as several subdomains. Again, I've plotted the relationship between our age diversity score and our outcome measure. Here, in this case, the CIQOL global score. And here we can see that individuals with greater age diversity represented in their networks tended to report better hearing-related quality of life. In this case, social network size, as well as accent diversity, also showed some moderate correlations with our outcome measures. However, the age diversity metric was really the most consistently related to outcomes. So these findings suggest that diverse networks may also lead to better perceived real-world functioning and overall well-being in adult CI users. So just to quickly summarize, social network diversity, and in particular age diversity, was related to both speech recognition and real-world functioning. This suggests that diverse social networks may provide both direct and indirect benefits consistent with prior research. Diverse networks may directly impact communication abilities through the diversity and richness of auditory input, and may indirectly impact communication abilities through motivation, support, and management of hearing loss. So obviously, more research needs to be done in order to better understand the relationship between social networks and communication outcomes in order to guide future interventions. So a current longitudinal study is investigating the direction of the relationship between social networks and communication outcomes to establish that social networks actually predict long-term outcomes. The study will also identify the critical social factors underlying this relationship, and it will determine sources of individual differences in both communication and social outcomes. So what can we learn from these results that can be used to improve outcomes? So one point is that auditory training that maximizes variability in talkers and linguistic content may be beneficial for adult CI users, in particular for adults who may not have or want large and diverse social networks. Second, counseling on different social communicative experiences that may help to improve outcomes could be beneficial to our adult CI users. This may help them identify certain real-world situations that may be manageable and may help them train their auditory skills. Finally, group rehabilitation approaches may help to directly and indirectly enhance communication and overall well-being, providing practice and auditory experience, as well as social support. So the key takeaway of the study was that although more research needs to be carried out, social network characteristics may represent important and potentially modifiable factors for improving speech recognition and real-world functional outcomes in adult CI users. I want to thank my colleagues and thank you all for listening.
Hello again, everyone. I'm Lindsay Zombeck, and so I wanted to talk with you a little bit today about starting an adult oral rehabilitation program and really serve to use this as a call to action to start referring more for adult oral rehabilitation and to get these programs going. So as I said previously, I'm with the University Hospitals Cleveland Medical Center, and I'm part of the cochlear implant team there and do see peds and adults. We're currently have made seeing adults part of our protocol for adults who get cochlear implants. So at this point, when an adult gets a surgery date and we start setting up all of their appointments with audiology for initial stimulation of the dates or of the cochlear implant, at that point they're also already scheduling their first oral rehabilitation appointment. So that's kind of the approach we're currently taking. I don't have any disclosures relevant to this presentation. So some of the challenge with oral rehabilitation, and I think we're kind of hearing it here, is what is oral rehabilitation? And the definition is ever changing and has definitely evolved. I think early on, a lot of times we've heard that oral rehabilitation was lip reading training, and it progressed till we got to this idea of auditory training was a lot more effective when somebody had a cochlear implant, and certainly advances in cochlear implants allowed us to make major gains with auditory training. But as we're hearing from everybody, it sounds like we're starting to move away from auditory training being the sole thing we need to be targeting in these services. So this is one of my preferred definitions of oral rehabilitation that ASHA used several years ago. But this concept that if you're getting oral rehabilitation, it's going to focus on adjusting to your hearing loss. We're going to be talking about things related to your amplification. We're going to be exploring assistive listening devices and things that are going to help you with hearing in real life functional situations. And we're going to help with conversation repair and managing conversations and your environment so that you can have the best possible listening situation and really taking charge of your communication. And that last part to me, I think, is what I really like about this definition. How do we help someone really take charge of their communication and be able to hear the best that they can and to communicate in all of the environments in which they're participating in their lives? So first I wanted to address that I think there's a lot of myths that prevent adults from getting oral rehabilitation. What's most frustrating to me personally is that all of these myths, in my mind, are myths that are held by providers and are not held by the patient. So these are things that some of us are doing as providers that are preventing adults from getting services that many of us are saying are gold standard services. So there's this thought that adults already hear well with their cochlear implant, so they will not need assistance. But we're seeing that adults are having changes in quality of life when they're doing various types of training. They're having benefit, they're reporting benefit in these areas. We're not necessarily just needing to look at audiology numbers to track how somebody's doing in terms of outcomes anymore. Another myth is that only advanced programming is needed. If we do the right things in audiology, if we program the right way, that adults are going to do well enough with their cochlear implants. And again, same as before, we're seeing that adults are seeking out more. They're needing more to be functional and to be very successful at work, and their lives, in their communities, in all of these different areas. Another myth we see is that it's really just the exception, the person who's struggling long term, that they're the person who needs oral rehab. But we're seeing that if we start things, as Dr. Dornhofer said, if we're starting things at 3 months, we're seeing benefits and quality of life. Why are we waiting until someone's been struggling for a year or 2 years before we're referring for oral rehabilitation? We can start this immediately because there's something we can be working on for anyone who gets a cochlear implant. There's also this concept that adults don't want oral rehabilitation. And I think we saw very definitively with Michelle's presentation that adults are wanting adult rehabilitation. Maybe they don't know about it, maybe they don't know how to access it, or maybe they're not getting the referrals for it, but they're interested. So we can't just make this assumption that adults don't want it. There's also the concern that insurance is not going to cover it. Why bother? I don't want to refer for something if somebody's not going to get coverage of it. And as Blair and Megan were talking about, their program's been very successful. 78% of their appointments were covered. If you're interested, I have a poster, it's number 222, and I just put out what our center's results were looking at the same type of thing. And for us, it was 88% of all people had all of their evaluations and therapies covered. And similarly to Blair and Megan, the exceptions when it wasn't covered were probably more related to coding or strange things like that versus an actual denial of services. So there's all these myths, and these are within our control, and these are things that we can work around by changing our perceptions and making those referrals for adults. So despite these myths, I'm happy to see there seems to be a change. There seems to be more providers, more ENTs, more audiologists. We're seeing the CI programs in general recommending oral rehabilitation. We're seeing CI-related organizations starting to say, yes, adults need oral rehabilitation too. So we're finally having this call to action, and we're seeing that it's recommended for adults who get cochlear implants to get oral rehabilitation. So when we're going to refer something, we want to know about the efficacy. Certainly we don't want to be asking people to use resources to participate in something that isn't going to be helping. A huge problem we have right now is that we don't have a lot of research. If you try to do a search and find, is oral rehabilitation effective, that study doesn't technically exist. What we do see is a lot of areas within oral rehabilitation have been studied, and we see that those areas are effective. So we know we have research support to show that if you work on environmental sounds and identifying environmental sounds, that we can see improved outcomes in those areas. We have research that shows that speech and quiet and speech and noise can be improved if those areas are specifically targeted in oral rehabilitation. We've seen the same with articulation or improvements in speech sounds. We've also seen improvements for people with cochlear implants in terms of music appreciation and telephone use. So there's areas that we know are within oral rehabilitation that are, it is effective to use oral rehabilitation to target those areas. What we really see is that we have a lot of research opportunities. We have opportunities to do a better job of showing that it's effective to use oral rehabilitation, that this is going to improve outcomes. We also probably need to have better discussions about protocols. What is oral rehabilitation these days? What should it include? What should we be doing in these services? Because a lot of people are doing a lot of different things. We also should be looking at things like frequency. Do adults need to come in weekly? Do they need to come in monthly? Like, how often should we be having these services to make benefit? And how long should we then continue these services and still see benefit and improved outcomes? We also need more research in the area of delivery methods. So I was really happy to see the information about some of the computer-based auditory training. And we need more information about telehealth. You know, a big study just came out showing that telehealth was very effective for children. We need that study for adults too, to show that telehealth is effective for adult oral rehab. And then also, what do we do for the in-person groups as well? Is that effective, and in what areas? As Dr. Darnhofer pointed out, is it in audiology booth testing where we're going to see results, or do we need to be looking at other types of measures so that we can capture these differences and these improvements in outcomes? So if you're thinking about starting oral rehabilitation, I think there's a big thought about guided or in-person versus computer-based auditory training. I think there's room for both, and I think there's probably a huge space for a blended model where we're using both types of services and that people can take advantage of both. So that's something to consider as you're thinking about what to involve in your auditory training. In terms of who is providing oral rehab at this point for adults, it's a variety of professionals. We know it's in the scope of practice of audiologists. It's in the scope of practice of speech-language pathologists. It's also in the scope of practice of teachers of the deaf, some of whom do work with adults. As it was mentioned earlier, I believe by Michelle, some of us started off as peds people who kind of got roped into the adult world, and I think that's often the case. But identifying people, and so that when you tell somebody go get oral rehab, don't make them go find it themselves. Like, have a name, have somebody that they can go to. The coverage and reimbursement, especially in the United States, may impact who's the provider. As was discussed earlier, Medicare does not reimburse audiologists for the CPT codes for oral rehabilitation that are most common, but do reimburse speech-language pathologists. It's hard, though, because an audiologist most of the time can't just not do oral rehabilitation. It's so ingrained in what audiologists do every day when they're working with their patients that you can't unbundle it. I mean, it happens. So it's an opportunity for true teamwork between everybody and members of the team, and good communication to make sure that the patient's whole person needs are being met. These are the codes that we use at our center, similar to what Blair and Megan were saying. We use the speech evaluation and treat codes. We have had the same problem with Aetna, and we have been using the 92630 and the 92633. It did get reimbursed. So we'll see what your experience is. It's a code that speech-language pathologists can bill. It is, when you read the definition of it, it's what we're doing. It's not telling you to do something fraudulent to switch the code on that. I would very much stand up and put my license on the line that that's the services that I'm providing. So reimbursement varies, is not historically high in the US, but can still be profitable. The 2024 national fee from the Medicare fee schedule is $223 basically for an eval and $75 for an eval or therapy, which is down from 2023. In general, we want to make oral rehabilitation common for adults. So identify people in your area so that people aren't having to seek it out themselves. Make sure everyone's on board. You get your best results when it's counseled preoperatively by everybody on your cochlear implant team. ENT should be saying these visits are going to be happening. Audiology should be saying these visits are going to be happening. We are, as much as you can, involving speech-language pathologists in the process. You may want to consider something like automatic referrals for adults, since people benefit regardless of their levels of presentation at initial stim, so that we're just getting all adults in for oral rehabilitation. And we got to get some research going. I mean, we've done some, and I love the research that this group has already started, but we need even more. So as you're forming your programs, really be thinking about how you can involve oral rehabilitation. So that concludes my portion of this, but I did want to bring up for, as we're starting our overall group discussion, these are some resources. So American Cochlear Implant Alliance has had an adult oral rehabilitation special interest group that started. And so that's an opportunity for something that professionals can join. And there's a lot of discussion happening. There's a lot of working together, looking at what needs to be created. You can do a much better job. We'll make sure you get a chance to talk about it. Blair is heading this up at the moment. So I don't know if I just did that or somebody did that because I'm talking long. But it's zoomed in so you can get the code. That's it, brilliant. So that's one of the opportunities. And then after you get a chance to get that, you can sign up here so that you're able to participate in the SIG and get more information and be part of some of these discussions and part of the policies that we're trying to get. The other one is a survey for adults who have cochlear implants who had experience with oral rehabilitation, just to help us gather more information about the experience. So that's another code that you can share with recipients, and I believe they can email you to get.
Is this working? Okay. Hi. So the survey, I can email both of these flyers to you. The email address that's on the bottom of each of the flyers, you can send a message there, and I will get back to you. My secretary, Claire, will get back to you. But you can feel free to send any questions to that email address, and I monitor it. But please join the group. We have a growing professional group with this SIG, and the commentary and the discussions that we've been having are really going to help us reshape adult oral rehab across the country, and we have so many plans and copious amounts of notes, and this survey is going to inform and support all of that. So share it with your centers and share it with your cochlear implant recipients. Thank you.
Great. So we want to take this opportunity to open this up for questions. If anybody has any questions for anyone or for the group, we'd love to have some discussions about what's happening in adult oral rehab world, and we'll let you go first.
If that's okay, thank you. So actually, this is a question for anybody and everyone. Very interested at the at-home practices, the computer-based auditory training. I'm a big auditory rehab person, audiologist. I have every single one of my patients do it, and I refer for every single patient. Yeah, right. So my question is, for those who either don't have coverage for formal auditory rehab, or those who choose to do computer-based or at-home practice, obviously like quality over quantity, but what's your recommendation when you tell them, you know, I have my long list of practice options, but how long do y'all tell them to practice on like a daily basis?
I tell my adults to practice literally every hour of the day. No, I'm just kidding. But
Constantly.
depending on how they're, what we're working on specifically, I'll give them catered exercises. And I have commentary on a handout that me and the team at Mass Eye and Ear that we created together that has my personal commentary on what I think about some of the apps and games that are out there. This is also, I think, a goal for the adult AR SIG. We want to collaborate really well together. Everyone seems to have their own list using the same applications, the same games. We would love to have a directory of sorts living on the ACIA website where you can go and have everything that's readily accessible to you out there. At this point, I have a handout with Mass Eye and Ear branding on it, and it's not games that we own. I would love to create one. I just don't have that time. Who does? But I will ask them to practice 3 to 5 days a week.
Okay.
Typically, my adults will do this during an activity. So I have them drink a cup of coffee in the morning and sit with their phone and practice. I have joked around that they could do it in the bathroom if they want. I don't care, just don't talk to me about it. As long as they're reporting that they're getting some benefit from the exercises, that's what I care about, because when I'm working with them, I'm also collecting data. And then I'm seeing in the measurable outcomes in the booth how they're doing.
I do what's probably a little controversial. Usually people give me eyebrows on it, but I recommend practicing every day for 5 minutes. And my rationale behind 5 minutes is when you tell somebody to practice for an hour, I haven't met an adult yet, regardless of age, who has an hour every day to practice. They are busy, and just because you're retired, you get busier, it seems. My goals on retirement have changed after working with adults, but people are so busy. So I say 5 minutes, because if they can commit to 5 minutes a day where they're truly working on it, most of the time when they get going, they'll give a little more time. It also prevents them from hitting the point of auditory fatigue, where they're so tired and they're just pushing through because they know they have to report back to you that they did it. So I just kind of say, hey, try 5 minutes. If you're tired and exhausted, you can't learn because your brain's tired and exhausted, give yourself a pat on the back and say, we're going to try this later today, or we're going to try this tomorrow. So I can usually get buy-in from people when they hear that it's only 5 minutes. So that's my personal approach.
I think we have time for one more question, and then if there are other questions that you want to ask the panel, please feel free to come up to them after or join us in a bit. But I think we'll go with one more question over here, and then we will conclude our session.
Thank you so much to the panel. Just one quick comment and a question. So comment about the 5 minutes. Even Duolingo, they say 15 to 20 minutes a day you can learn a new language. So sure, 5 minutes, I totally love that idea. For a lot of patients too, when you are going through the insurance and they give you a certain amount of sessions that you can do, after they are done, is there a recommendation for the patient? I know, Lindsay, you mentioned that who knows how often afterwards, but is it twice a week if you can do it? What's the recommendation that you guys tell your patients after you've come in person or through Zoom with me that we should, at home, you should continue doing this therapy?
Do you mean carryover? Beyond, like once they're discharged?
Yeah, once they're done with the oral rehab with you guys via Zoom, even if they're doing the apps at home, do you say twice a week should be enough for the rest of your life? Like, what are you looking to achieve with them? I know it's hard.
For my adults, if they've been discharged from therapy, they're not typically working on some of the bottom-up skills that are built into those apps, and they've probably cycled through the games and exercises online that like telephone practice or sound success that have a more top-down approach. So it becomes more functional listening and use of their technology in normal communication environments and with friends and family at that point.
All right, thank you to all of our presenters. This was a fantastic afternoon, both the pediatric session and the adult session. So thank all of you. I thank all of you who attended. I am excited to see this many people interested in adult rehab, and please take to heart the call to action to both engage in as much research as possible related to adult AR and to helping your programs develop adult AR programs in the coming time frame. So thank you all very much. At this point, I would like to invite Teresa Caraway back to the podium, and she magically appeared. And so take it away, Teresa.
Wow, what another great session. Thank you each. Adult rehab, just the fact that everyone in this room touched the lives of so many people and make a difference. And that's what Hearing First is all about, is learning and growing together how to up-level our practice. So I'd love to invite you, encourage you to come join us in Ballroom C for appetizers and a drink. We'd love to connect with you. Members of the Oberkotter Foundation team and Hearing First team will be in the room. But most importantly, we learn when we engage with each other and dialogue and have deep discussions. And so please, we also invite you to join the Hearing First learning community, where you can take advantage of every single day connecting with friends in your pocket to up-level your practice and experience great learning experiences and CEUs at no charge. So come join us. I'd love to connect with you, want to hear your ideas. And thank you so much to Donna Sorkin, the ACIA staff. They're mean, lean, and a fighting machine to pull off this kind of conference. And thank you, Amy, for coordinating the afternoon for Rehab Connect. So anyway, have a great evening, and I hope to see you in Ballroom C. Thank you.